what I'm going to do in the next 20 minutes or so is give you really a very brief introduction to what I do. And unlike Ron, who is really at the front line, as a microbiologist, I do a bit of work in the laboratory and a bit of work on the front line as well. So for those of you who suffer from chronic insomnia, I'd recommend reading this report, which is the World Economic Forum report. It's the most depressing report I've ever read in my life. And it really talks about all the bad things happening in the world, things like climate change, terrorism, et cetera, et cetera. But what this graph basically shows is the likelihood of a problem against the impact. And I just want to focus down, if I may, on the top left-hand corner. So you can see there, we've got the spread of infectious diseases as being something that they believe to be of low likelihood, but of high impact. If you look at the other slide, that's sort of up with things like sort of fiscal crises. So it's going to be a very serious problem, and I think it is on the horizon. So these figures are from the ONS a survey talking about how our population will change over the next few years. And what we can clearly see over the next 25 years, we'll be seeing many more members of our population who are older, more frail, more vulnerable. And we know that by mid-2027, the population should reach around about 70 million in the UK, which is a huge burden on the NHS and on other resources. The average age by 2039 will increase by 2 years to 42.9, and again, that reflects a changing demographic in our population. But what's more interesting is that by 2039, 1 in every 12 people living in the UK will be over the age of 80, and they're going to be at risk of recurrent infections, sepsis. They will be experienced in terms of hospital exposure, and they may be carrying with them resistant bugs as well. So it's a real sort of geographical problem for the UK in particular. So these are Public Health England infographics which have recently been published, and these really summarize where we are at the current moment. So currently there are 74 out of every 100,000 people will suffer from an E. coli bacteremia. Looking at the slide on the right-hand side there, you can see this is an increasing trend. It's been increasing from 2013, and it's on the way up still. These really talk about the differences between men and women. So men are slightly more vulnerable to E. coli bacteremias than women are. The age group in the left-hand side is 45 to 64. I'm very nervous not to refer to those age groups as middle-aged, so I'm almost getting there myself. So they're not middle-aged, they are still relatively young people. And then on the right, we can see that, again, there's an increase in terms of preponderance of males over the age of 85, nearly 900 per 100,000 cases. And that's a very stark difference to women, which is 621 cases per 100,000. One of the things we're looking at in very much detail, and I'll show you our local data later, is where do these E. coli bacteremias come from? So again, this is National Public Health England data showing that about half of the UTIs that go on to cause an E. coli bacteremia are due to UTIs. Now, in terms of where those UTIs come from, as you can see on the right, the majority, more than 3/4, are what we call community onset, which occur within the first 2 days of hospitalization. 20% or so, the remaining 20%, occur after that, although, as I'll come on to explain later, that definition is now changing. This was put up by the Department of Health on their website in October of last year, and I've just sort of picked out 4 key issues that they've raised. One really is that the focus of IPC teams within NHS trusts should now be geared towards looking at E. coli bacteremias. So to put that into context, we've already got to worry about C. diff, MRSA, MSSA, and now E. coli as well. So there are 4 main indices we've got to be looking at and measuring. The feeling from DOH is very much the E. coli bacteremias should be preventable and can be prevented through early diagnosis, early treatment, and essentially the prudent use of antibiotics. But the key thing to also remember is that the management of E. coli bacteremias is part of a package that we perform within infection control, and that really, in my mind, is screening, cleaning, hand hygiene, and antimicrobial stewardship. These are the 4 pillars, if you like, of IPC. And so when we talk about reducing any hospital-acquired infection, we've got to also consider our hand hygiene rates, which over time there'll be an expectation that we will publish those for the public to see. So where are we in terms of our national incentive schemes? Well, where we were historically for 2015-17 rotation, there was a quality premium looking at antibiotic prescribing within primary care. Then, which Ron has touched on already, was the sepsis sequin, both for 15-16 financial year and the previous financial year, looking at screening and timely management. And for the last financial year, there was a sequence looking at how we can reduce antibiotic prescribing within our hospitals, and we can also look at the reviews of those prescriptions. So the key thing really for us was, in my organisation, early de-escalation of antibiotics and clear evidence in the clinical notes that that prescription has been reviewed by someone in authority, usually a registrar or above. Where are we going next? Well, really the sequence for the next 2 financial years, the 2017 axis, is very much going to be looking at how we reduce the impact of quite serious infection, and importantly, how we reduce gram-negative bloodstream infection. So the NHS England ambition really talks about a 50% reduction in our gram-negative bacteremia rates across the whole health economy, both primary care and secondary care, as well as a 50% reduction of our antibiotic prescribing, again, across primary and secondary care. So in terms of the gram-negative bloodstream infection, which is GNBSI, the equality premium is in 3 main parts. Part A is reducing the whole of the health economy's worth of gram-negative bloodstream infections, and that's worth approximately 45% of payment. We've then got reduction of inappropriate prescribing for UTIs in primary care, again worth 45%. And then finally, a sustained reduction in prescribing in primary care worth 10%. So all of these modalities together really will help encourage and drive both prescribers and those involved with prescribing to bring their performance in line with these quality premiums. So that's all very well. We've seen what PHE have said. We've seen what the DOH have said. The big question I'm faced with as the infection control director is, that's fine, how am I going to deliver it? Well, I think the delivery really is to understand the scale of the problem locally. You may find that where you're working, your population may be different, your demographic may be different. You may have a high proportion of older patients or younger patients, or you might be a quaternary referral centre with lots of surgical patients. So first of all, know your patient group. That's the first thing. Once you've done that, then the key thing is data mining. So I'll come on to show you some data later where we've spent a lot of time looking at our laboratory reportable data, looking at our patient demographics, and looking at our resistance profiles. Then the next thing is define who your stakeholders are. And for me, the stakeholders are the people on the front line, like Ron, who are the primary caregivers, the responsible physicians who've got their name above the end of the bed, who are going to be really looking after the patient. And they're going to be instrumental in terms of how they prescribe. I'm not being unkind in saying that there's a spectrum of thoughts amongst consultant colleagues. Some are very dynamic, some are very set in their ways, I suppose. And so bringing all these people around requires some careful thought. But also, don't forget the other people responsible in helping you manage those prescriptions, the pharmacists. Now, most secondary care organisations have got antimicrobial pharmacists. Some have got a number. We are now seeing these individuals in primary care as well, and together we can work with them to look at prescribing. Healthcare epidemiologists are important because what they will do is they will mine the laboratory data, they will mine the clinical data, and also look at the performance of the hospital in terms of defining your denominator data, i.e. your index per 100,000 bed days. And finally, laboratory scientists, who will basically liaise with the front end of the laboratory in terms of have we got the best test? Are we performing within the PHE guidelines? Can we get results out more quickly? Do we need to adopt new technologies? So really, all of these people in my mind are key stakeholders. The key thing I suppose to really say is that at the current moment, the cause of the increase in E. coli bacteremia is very much unknown. And this paper published in the Journal of Hospital Infection really did a sentinel study to look at that in a bit more detail. And they covered around about 1,700 patients with E. coli bacteremias, breaking them down into their age and also the appropriate cause of infection. Now, based upon their study, they felt about half of their patients did have an E. coli bacteremia secondary to UTIs, and that really is very congruent with the PHE data. But importantly, what they looked at, interestingly, was when those patients came in, how they interacted with healthcare prior to their admission. And what they found is that a proportion of those patients who had E. coli bacteremias had device-related infections. And of course, the commonest device that we see are urinary catheters. But what we're finding is that as time goes on, we are seeing more and more resistant gram-negatives, And if you look at those proportion of patients, they have had previous exposure to healthcare previously. So patients who are revolving door patients, who've got recurrent UTIs, increasing exposure to antibiotics breeds resistance, and that breeds increasing risk not only of gram-negative bacteremias like E. coli, but importantly, resistant gram-negative bacteremias. So this is hot off the press. I think I got this off the PHE website a day or so ago, really looking at how we're going to redefine our approach to infections. And really what we're talking about now is thinking about our patients as they come through the door. Have they had exposure to the healthcare 28 days before admission, or is it after admission? And whilst we historically have thought about our bacteremias and our C. diffs as pre-hospital and post-hospital, i.e. pre a problem that occurs in the first 48 hours, post occurring after 48 hours of admission, that's now going to be changing. And I think this definition is important because it then really encompasses the whole health economy rather than simply saying, well, that's a hospital problem, that's a community problem. It brings both community and secondary care together quite nicely. So in terms of mining our local laboratory data, in Birmingham we've got access to this system, which is called the second generation surveillance system, and that allows us to mine our local data to see how many patients we've got with infections, and we're looking at their resistance profiles. Now what that system also does, because the laboratory data is reported to PHE, we can access the national data. So this really is looking at the national data of E. coli bloodstream infections and looking at resistances of various antibiotics down the side. Now, I'm not going to bore you with the detail, but the key thing is looking at these lines. We're not seeing huge increases at the moment in terms of resistance, although I think that's going to come over time. But importantly, what you'll find in national figures is your local figures get lost in that data, and our local figures do look slightly different to this. So in terms of the Heart of England Foundation Trust, we've done a lot of work in terms of trying to understand our E. coli journey. And what we did first was develop a group of like-minded individuals to form a high-impact intervention group. We've then rationalized the equipment, the sorts of catheters that we use. We've got a urinary catheter care plan or a pathway, and I'll come on to talk about that in a moment, and also a catheter care passport. Now, this passport is very similar to the old books that patients had when they were on warfarin, and this really gives patients ownership in terms of the catheter. They all know when it went in, who their urologist is, what type of catheter it is, when it's due for a change, and it really empowers patients in terms of understanding they've got a catheter and they can do their bit in terms of preventing future complications or future infections. Now, what we also did within our local data was really look at, with the old definition of pre and post, how many of our patients had E. coli bacteremias. We had 135 quotes pre-patients and 21 post. But interestingly, if you look at the breakdown, you can see the majority of our patients who came in through the doors with an E. coli bacteremia were urinary related. But importantly, within that group, there are a group who've had hepatobiliary causes, so things like gallbladder infections and biliary infections, and also a proportion who've got respiratory infections, which I found very bizarre. Historically, we are taught as microbiologists that gram-negatives don't cause chest infections, but certainly in our case, with careful review, we thought they did. And also not forgetting the unknown cause. And importantly, out of our post-48-hour patients, 5 of the 21, we could not find any good reason why this patient should have a an E. coli bacteremia. The MSU was negative, there were no other clinical signs, and yet, bang, they had an E. coli bacteremia. Now, if we look at those numbers in more detail, what we then looked at were the levels of preventability. So out of our 59 patients we thought were preventable, we had 50 that were in the pre-48-hour group and 9 in the post-48-hour group. And then drilling down into that data further, again, some themes come out in terms of urinary tract infections being a common source, but also we found some hepatobiliary sources, and our 4 respiratory patients are still part of that pre-cohort. So in terms of the preventable features, what we've been looking at are really a number of things. We've been looking at instrumentation of our patients, and that instrumentation may simply be the insertion of a catheter, or it may be a urological procedure. Here we're really talking about patients who've had procedures to have their prostates operated upon. And also, if they have had urinary catheters put in either pre or post-operatively, again, a catheter-associated sepsis is something we've been looking at. And it's not just bloodstream infections now that we see with vascular catheters. We are now seeing bloodstream infections with urinary catheters. And what we are also finding more and more is when we see patients coming through the door, we want to mine their laboratory data to see when did they last have an E. coli UTI, who sent it, was it the GP, was it primary care? If it's come to the laboratory, what was its sensitivity profile like? How does that compare to the bacteremia? And is there a current sample to compare as well? So there are lots of different indexes we can use to look at the previous E. coli exposure. And what we are finding initially as part of our C. diff reviews is when we go back to look at the prescribing within the community, although we've got very clear community guidelines, sometimes our patients within the community are complex. They may be symptomatic. They may have mixed growth on a UTI, and that doesn't always give the GP the best direction to go in. So sometimes GPs are treating their patients based upon their own judgment, and sometimes with the benefit of hindsight and a follow-up follow-up MSU, that can actually be incorrect. So working with primary care doctors in terms of how we diagnose UTIs and how we manage our clinical reports. And the last complication is pyelonephritis, an infection, an ascending UTI, really with infection of the kidney itself, then going on to cause sepsis, and that's due to an E. coli bacteremia. And based upon that infographic I showed you from NHS England, really looking at the previous hospital admissions within the last 3 months. Has the patient recently been into our hospital or another hospital? And if they've been to our hospital, what is their microbiological, what are their results like? And of course, recent surgery as well. So putting all of that together then, when thinking about an E. coli bloodstream infection, there are a number of things that we need to look at. So we look at devices, and that can be either urinary catheters or other devices. We can look to see who are our high-risk patients, those who have had surgery, those who have had instrumentation, those who are elderly, those who are known to carry resistant infections. We look to see if they've got previous skin and soft tissue infections or wounds. We look to see what their UTI history is like. So have they had recurrent UTIs? Have we got positive microbiology? Are they on prophylaxis? And importantly, all of that feeds into our antimicrobial resistance strategy, where we think about, can we give the right antibiotic for the right patient at the right time? Can we de-escalate appropriately? Can we cessate our antibiotics after 5 days? So where do we go from here? So as far as the data flow is concerned, all hospitals, and ours is no different, we are duty-bound to report in a mandatory fashion all of our infections to Public Health England. And that will be E. coli, of course, now, as well as C. diff, MRSA, and MSSA. What we're doing at the moment is we are going to start looking at those patients who've got E. coli bacteremias who fit into a predefined criteria. They will go through a root cause analysis process where there'll be analysis by a microbiologist, an infection control nurse, and a pharmacist, and then they will then meet with the primary caregiving physicians, the surgeons or the physicians, and obviously the nursing staff as well. We've got to think about how we work in partnership with community. So we are already forming links with our 3 CCGs that cover my hospital. We've got links with their IPCNs and, importantly, the community pharmacists to see how we can improve prescribing at a practice level. And going on from that, of course, is we're now forming outreach programs to go out to our GPs and educate them in terms of, these are your patients, this is your data, this is your prescribing, let's look to see how we can work together to improve it. And of course, one of our main functions as microbiologists and infection control people is to promote antibiotic stewardship. And that's across the whole board. That will be for patients, it'll be for doctors, it'll be for nurses and pharmacists as well. And what we're having a big drive locally is really thinking about the role of the nurse within antibiotic stewardship. And the way I view it is that when the nurse is doing the drug round of all of the patients, the nurse who's giving that drug is the last defense between the antibiotic and that patient. And so we are empowering our nurses to check prescriptions, to challenge doctors, to think about de-escalation and think about early cessation of therapy. And obviously in the community setting, we can empower the patient to have some discussion with their GP about prescribing as well. We've set up an E. coli database. It's just a spreadsheet at the moment. We're going to be collating all of our clinical data and all of our infection control data as well. And importantly, we'll continue our work with our catheter passport and our urinary catheter team and our continence team to improve the use of catheters within our organization. Obviously, how we approach urinary tract infections and urinary catheters is going to be part of a much more broad national program. And you know, the to dip or not to dip hashtag is part of that national campaign. We've also got to consider other factors. We've got to consider the geography of patients, the migratory nature of patients. In Birmingham, our patients travel abroad quite a lot, to the Middle East, to the Far East. We've got to factor that in as well. And importantly, we've got to think about the demographic of our patients in terms of age. Clearly, older patients will require more intervention. One thing that we've been struggling with in our particular hospital, we've seen this over the last few years, is we do get summer peaks of E. coli bacteremias. And we've been digging into the literature to really see why that is. So I think our own view, and this is really supported by some work in the literature, is that older patients, they get dehydrated during the summer months. They don't drink as much. If they're in hospital and they're demented, you know, we need to really be pushing oral fluids in these patients. And I think because of that, they become dehydrated, they then develop UTIs, and they go on to develop E. coli bacteremias. And I think there is a causal relationship there. And the key thing, I think, is really going to be how we manage those patients. Can we avoid catheterizing them if we can maintain their skin integrity? Can we push oral fluids appropriately? Can we push IV fluids? Do the relatives and the other allied health professionals have a role in terms of encouraging our patients to drink appropriately? So this is just my last slide. I'm sorry I rattled through that a little bit fast. Really, I just wanted to give in the last slide a thought in terms of how we move on into the future. So clearly, we've heard a lot about antibiotics, a lot about resistance, but what are the next steps? And I think the next steps are really thinking about compounds outside of the antibiotic envelope. And so there's been a recent paper published looking at other compounds which work in vitro models to prevent E. coli infections. And so this is a combination of various extracts, including a plant extract from hibiscus, showing that not only if it's used in an in vivo model, it can maintain the integrity of E. coli, but importantly, it can prevent the adherence of uropathogenic E. coli to cell surfaces. And that could be important in the future in terms of patients who've got E. coli catheter infections may then prevent them from getting E. coli bacteremias in the future. And that's the hibiscus plant, in case you want to know what it looks like. So that's the first arm. The second arm, I think, which is very interesting now, is thinking about the role of things like bacteriophages. And bacteriophages are viruses that infect bacteria. They break the bacteria open, but they aren't technically an antibiotic. They don't suffer from resistance problems as antibiotics do. And what we know is that they break open their cells by replicating inside those cells. Although we have no experience of this in the UK, evidence from Eastern Europe does show that commercial cocktails do have a role in preventing E. coli infections. And certainly if you take an in vitro model of urinary bladder cells, you then infect those cells with E. coli, you then put phages over the top, you can not only break open those E. colis and reduce the infection, you can also prevent that E. coli coming back. And I think that's very important in terms of thinking about how we manage with our resistance in the future. I mean, as you probably heard, the pipeline for gram-negatives is not fantastic. We have got new drugs coming in, but that's against the shadow of things like multi-drug-resistant E. coli, and also the new thing we're dealing with, which is the carbapenemase-producing Enterobacteriaceae. These are SEPA-resistant bugs, which can't be treated with things like meropenem or ertapenem. So when faced with this sort of very gloomy picture, it's time to start thinking outside the box, and these are two potential methods to do that. And that's what a bacteriophage looks like, in case you're wondering.